For those who aren't familiar, the Refugee Advocacy Lab is an initiative co-founded by Refugees International, IRAP, the International Rescue Committee, and Refugee Congress. We also partner closely with Church World Service and our co-sponsors for this event today, the Center for Victims of Torture, or CVT. The lab seeks to support the advocacy community by developing strategic communication resources, championing inclusive policies, and building capacity for the field. One of the ways that we build capacity is by creating resources and thought leadership products. And today we're very excited to launch a new resource on refugee mental health. This report was created in direct response to calls from the field, including from refugee leaders, for a policy guide highlighting opportunities for refugee mental health advocacy. In a recent survey of forcibly displaced people, access to mental health services ranked in the top 5 issues highlighted as being a key determinant of successful integration. We hope this resource will serve as a primer and roadmap for advocates interested in refugee mental health policy. And I'd like to spend some time to quickly highlight, the contents of the report. The report highlights opportunities for engagement both at the federal and state levels. It provides an overview of the mental health infrastructure in this country, including various programs available through the Office of Refugee Resettlement, the Substance Abuse and Mental Health Administration, or commonly referred to as SAMHSA, and Medicaid and CHIP. The report also includes an advocacy checklist to help guide the thinking around pursuing any of these policy proposals. In the executive summary of the report, we highlight some of the key takeaways and our recommendations from our research. There's 3 main themes that emerged from our overview of refugee mental health access. First, overall, there's a need for a coordinated nationwide strategy that addresses access to mental health for refugees and other forcibly displaced people, accompanied by long-term and consistent investments of funding by Congress and the relevant federal agencies. Similarly, few states have implemented a statewide strategy to coordinate mental health promotion and services for refugees. Second, despite a recent flurry of programming and funding both at the federal and state levels to address health and mental health inequity for underserved populations, few identify refugees and forcibly displaced people as a unique category, despite increasing recognition of immigration and displacement as a social determinant of health and mental health outcomes. And finally, with current nationwide shortages of behavioral health professionals, investment in workforce development programs is a dire need in many communities, and this shortage is acutely felt by newcomers. The federal government and states must prioritize improving the cultural and linguistic diversity of the mental health workforce and reduce licensing barriers for foreign-trained practitioners. States in particular can really play an outsized role in ensuring refugees and displaced people are not left behind. When states make common sense investment and policy reforms to improve access to mental health, they stand to gain not only from improved integration outcomes amongst new Americans, but also decreased healthcare costs in the long run. We hope you'll find this report a useful starting point as you explore advocacy strategies within your own states or localities. We at the lab are here as a resource for you all, and we're available to answer questions, provide technical support, and amplify or uplift any efforts within your states. I'd like to now introduce and thank our panelists for joining us today. They come to this panel representing a unique perspective from the field, and we'll have an opportunity to hear a little about the work they do. We'll cover some of the barriers refugees and displaced people face generally as they try to access mental health services, and then we'll move into a discussion of some best practices and general advocacy advice with examples from Virginia and Georgia. First, we have joining us is Dr. Omar Rida, who's a board-certified psychiatrist, Harvard-trained trauma expert, humanitarian, and author who's devoted much of his career to helping people recover from psychological trauma. Trained as a medical doctor in his home country of Libya, Dr. Rida fled in 1999 due to his humanitarian work. After settling in the US, he went to train at Harvard and the University of Tennessee and is considered a global trauma expert who has consulted for the UN and the World Health Organization. We also have joining us Dr. Eva Stitt, who is the Refugee Behavioral Health Coordinator at the Office of Behavioral Health and Wellness within the Virginia Department of Behavioral Health and Development Services. She has designed various psychological assessments and curriculum materials relating to refugee mental health, and she currently coordinates the Virginia Refugee Health Partnership, which is a statewide initiative to establish sustainable public-private collaborations to ensure refugee access to mental health care. And last but not least, our lab state lead from Georgia, Darlene Lynch, who's also the head of external relations for CVT in Georgia. She currently chairs the Coalition of Refugee Service Agencies, leading various advocacy efforts promoting inclusive policies in Georgia. She's a longtime human rights advocate and experienced lawyer. Before we begin our conversation, I'd like to note for our audience that we'll have an opportunity for a Q&A at the end, and you're welcome to submit questions in the Q&A function in Zoom. So Dr. Rida, I'd like to start with you. You have lived experience as a forcibly displaced person and the professional expertise as a practitioner in the field. I think before we delve into the policy discussion, it's important for our audience to hear from you how you came to work with refugees and your approach to providing trauma-informed and culturally competent care to clients.
Yeah, thank you, Balqis, and it's really my pleasure and honor to be with the group. And yeah, I mean, in Libya, I was working as an emergency room physician, actually. But even then, I was quite attracted to the trauma story and spending time just trying to help my clients with the invisible wounds, the psychosocial impacts of trauma. And I never expected to leave Libya. But one day I came home, I found my father urging me to immediately leave the country, was quite involved in humanitarian activities. And unfortunately, my name was, identified as somebody who needs to be arrested and thrown in jail. So I ended up taking a boat, crossing the Mediterranean Sea to the United Kingdom, where I lived as an asylum seeker. And even in England, my asylum application was denied because there was no evidence of physical torture on my body. And I was, somebody who really advocates for many times the scars of trauma on our mind, our heart, our soul. And this is what led me to the field. And then after that, of course, coming to the United States after September 11, going through some traumatic experiences there, moving into Libya during the civil war in 2011, and finding myself flying to different refugee camps and trying to just work with trauma survivors on multiple projects.
Thank you. And, as a fellow second generation Libyan, I totally understand, or I can understand some of that trauma, and what happened in Libya is very unfortunate under the former regime, and currently extends to this day and age. I wanted to kind of hear from you if you can speak to the barriers that you see your clients facing. I understand you work with clients now in Colorado and previously in Oregon. What do you see as the greatest barriers to access for mental health services amongst your clients?
Mm-hmm. Yeah, I mean, my day job is a practicing psychiatrist in an inpatient unit. So I see all kinds of clients, but then, I work 1 week on, 1 week off now with the University of Colorado. We just moved here from Oregon. And, during my week off and in the evenings and the weekends, I usually do lots of psychosocial activities for refugees. In Oregon, we worked mainly with the refugees from Syria. But in Colorado, looks like lots of Afghans. So I've been doing programs with the Afghan fathers mainly. As we know, many of the psychosocial activities usually are well received by women and children, but there is lots of resistance, I would say, to any psychosocial intervention when it comes to men, especially if the program is not speaking their cultural language. So coming from Muslim background and trying to craft some interventions based on cultural resources, like using the Quran, for example, the Muslims' holy book, and also traditions from different prophets on how they coped with their own trauma, has been very well received in Colorado so far. And we also run, camps and retreats for traumatized children. Some of them have to do with the connection. We call it Camp Sila. And some have to do with skill building. We call it Camp Mahara. Mahara in Arabic means skill building, and Sila in Arabic means connection. And sometimes we use even animals for example, working with the Afghan children, we use the traumatized horses that had been rehabilitated to work with the traumatized children that hopefully will be healed through multiple comprehensive approaches. And I am somebody who believes that healing happens in different capacities. There is not one tool in our toolkit, but even with the resources and the services we provide, I would say there is lots of stigma. So many people don't come to our places of healing. And that's why I think we need to have organic, structures. We go to the community where they are. If they want to meet in the mosque, for example, if they want to meet in a place of a community gathering, if they want to do it informally, if they don't want to do it over, potluck or using cultural, traditions and celebrations and rituals. So I think the approach for my colleagues, should be one of a humility, a flexibility, and curiosity. So sit down with the local, group and learn from them. We don't come across as the expert on a culture, because that's, I think, a little bit arrogant of an approach. And so we listen to the local community, listen to their needs, their current services, resources, any gaps, and then we step in with an intervention that we co-craft together. So stigma is a big one. The second one is allocation of funds. I would say it has been very interesting to see how programs are funded. Some programs that get lots of funding, sometimes they focus on quantitative measures, and I am okay with collecting data because this is how we justify programs for donors. At the same time, the work we do really has lots of qualitative data to it. So when I have an intervention that's based on how to bond children with their parents or how to improve marriage dynamics, there is very little, quantitative or data that based on numbers. I would say we can collect that, but the main impact is mainly on the qualitative measures. What I have seen also, many times we open a space and we get overwhelmed very quickly. So once you open a healing space as a culturally responsive practitioner, many times you reach capacity very quickly. So I would advocate for both, building training for colleagues that are not from the Afghan culture, for example, but they are quote unquote Afghan friendly. And at the same time, we remove any barriers from maybe internationally trained, practitioners like doctors and nurses and others. Because when I came to the United States in 2002, I had to go through the USMLE, the United States Medical License Exam. It is 4 steps. It's quite extensive. You have to pass the English proficiency. Luckily, I did that in the United States. In the United Kingdom, their English language exam called the IELTS was very, very difficult to pass. So you score 7 in every section. I scored 7 in 3 sections and 6 in the 4th one, and I was unable to get my qualification in the United Kingdom. So there are many barriers, and I think there is lots of work that we can do as a group to remove these barriers.
Thank you, Dr. Rida. That's very instructive, and there's so much in there to unpack, and I wish we had more time to delve into each of those barriers, because I think they could be a webinar on their own. But unfortunately, we're limited in time. But I do want to hear from you, based on these barriers. We have a lot of people in the audience who are either legislators or advocates, or people in state agencies that might have some leverage over some policy making. What advice do you have for them to improve access for refugees, and what policies do you think they should really prioritize?
Yeah, I mean, I would say it's very important to find the right allies, if you like, from the local, community. For example, one time I was in Libya with the international organization. They do wonderful work. So they called me the last day that they had to leave Libya. And they said, Omar, we have $2,000 that we have to spend before the end of the day in order to meet our budget and continue to receive funds in the future. And I was very excited because in the city of Misrata, where I was located, you know, I told them we can build 6 different playgrounds around the city. And each playground in Libya cost about $300. So it was very affordable. 2,000 will build about 6 or 7 playgrounds. And they were very excited to hear the idea, the local staff. But then when they reach out to headquarters, and they told them that cannot be authorized because of short notice. And unfortunately, that $2,000 were spent on pizza and goodbye party for the staff, which I can appreciate. I mean, we need to appreciate our staff. At the same time, I was very disappointed that thousands of children were not given the opportunity to engage in play and art and other healing activities. So I would say work closely with the local community, make sure that you have cultural navigators and professionals from the community that you listen to, and then invite people to the table. The table sometimes seems very exclusive club. I would say many times, because of my own experience as a quote unquote an expert on refugee trauma, and also being very vocal, I'm very confident telling my trauma story. I think it's moral responsibility for people like me to speak up and demand a seat at the table. So make sure that if refugees and asylum seekers are not represented in these, meetings, that you ask why, and be proactive in reaching out to the community and inviting them.
Absolutely. I think centering refugee voices is, an important aspect of any legislative or policy advocacy. And clearly they need to be at the table because, especially in the field of mental health, where culturally responsive and linguistically responsive services are so important. It's, it can't be understated. Thank you, Dr. Rida, for those points. And now I'm going to move on to Dr. Stitt to share a little about her work in Virginia. Virginia's, was a unique example that emerged from our research. It was one of the few states, Dr. Stitt, you're basically a walking best practice in human form because you're a refugee behavioral health coordinator, which is a position that isn't very common in many states. And Virginia implemented a statewide approach to refugee mental health access that permeates throughout the state in locations with large refugee populations. I was wondering if you could tell us more about the Virginia Refugee Healing Partnership that you worked to establish in Virginia and how it works towards improving access to mental health support for refugees.
Thank you, Balkis, and good afternoon to everyone. Sometimes if you are not from the US or in the other parts of the US, it might be a morning. But anyway, wherever you are, greetings to all of you. So my name is Dr. Stitt, and I've been working with the Virginia Refugee Healing Partnership, VRHP for short, which is a partnership and a collaboration between the Virginia Department of Social Services Office of New Americans. This is the office that oversees the refugee program for the state, and my department, which is the Virginia Department of Behavioral Health Developmental Services Office of Behavioral Health Wellness. So specific to mental health, we created this in 2013. I used to be working as a staff in a refugee resettlement office. And I have a very nice community-based program, but then we don't have funds. And then here comes the state, a director who saw how nice it would be to have a community-based mental health program, and she has fund, but she has no program. So in short, with us working together, I have a program with no fund. She had funds with no program. We translated that into the Virginia Refugee Healing Partnership. And it's been a very successful endeavor, all because we have made sustainable progress. With this, I mean that we are not just operating at the state level. We have different community-based coalitions across the state where um, refugees are resettled. And these community-based coalitions are the ones who are acting like a think tank and a broker between what is needed in the community for direct service and what we can offer at the state level. So just having this group and meeting regularly takes a lot of pressures and provides a pathway for all of us to connect and collaborate. It's kind of very efficient actually because we can speed up the process considering the number and the quality of the interactions and collaborations that happens in the Refugee Mental Health Council. But then my work as the state level is providing technical, um, administrative sometimes, resources and support to our different councils so that they are able to do their job in many ways possible. So in short, it's a multi-level support and cooperation because it just cannot happen with me at the state level or with them at the local level, but a multi uh, and diverse community, a multi-sectoral and diverse community make it happen. And I'm really very proud of what we have accomplished so far.
Can you elaborate just a little more on what multi-sectoral is? Who are the participants in the partnership, and who are like the key collaborators?
So for example, I'll give you within the Northern Virginia Coalition for Refugee Wellness, for example, we have representations from George Mason University. We have representations from the Community Services Board. We have several community-based organizations such as One Journey. We have also from the health department within the local community. We have representatives from the refugee groups. We have community partners uh, like those in the trauma setting. We have clinicians who are with us. So when I say multi-sectoral and diverse, it's really multi-sectoral representatives within that coalition. So if we need something, someone has an idea what to do with it because addressing the needs and resources needed by refugees in matters of refugee mental health is huge. As mentioned, we don't have enough clinicians. So to have one clinician is a very good start to tell us where can we refer to, who is available. Otherwise, if someone needs care and treatment and they need to wait for 3 months before they can be seen, they're already in crisis before we can even give them the care they need. So having a coalition with all these multi-race representatives enable us to be more efficient and as much as possible address the need as soon as possible.
Thank you, Dr. Stitt, for elaborating on that. If what would you say, from that experience, are 2 or 3 best practices that you would elevate as important for states to support refugee mental health?
Okay, 3 best practices. I would prioritize one, a sustainable community-based programming, all because if we just depend on the state cannot address everything. And besides, the state does not have a very big picture of what's in different localities. So we cannot just make a cookie, cookie cutter programming that is coming from the state. We got to work with people at the local level because they know more about the needs and they know more about the resources. So this collaborative effort by building a sustainable community-based programming really makes a lot of difference in terms of how effective we can be in bringing programming to the community level, and how these people in our community will respond to the program that we're bringing in. Because without the response, our program is not effective. It's not sustainable. It has probably very, very less value, even if we put so much fun in it, which I say funds are limited anyway. So we're looking at the quality of program based on the needs and priorities of the local community. And we can do that using a community-based programming. The other part, probably best practice, is a written policy on hiring of qualified interpreters to support language access services. We understand that there are lots of highly educated refugees and immigrants who are in our community, but still there are many others who need uh, treatment, care, and support, but are not proficient in English. And so we don't have enough clinicians who speak the language of the clients, right? And so one of the best ways to facilitate access to communication is by having qualified interpreters. They don't have to be certified as in passing a national test, but rather they have adequate training to ensure that they maintain the message and the communication and the interaction between our limited English proficient clients, which could be refugees and immigrants, and the clinicians or providers or doctors or anybody who will be helping them. Because if the message is not transmitted accurately, there goes our problem. No matter how good your doctor, if the message is not transmitted correctly, there goes the expertise of that doctor. So having a written policy on hiring qualified interpreters makes a lot of sense. And then probably the third one is, and I think any program needs funding. It could be it could be something to start off a program. It doesn't have to be overwhelming because funding is always limited. But within the limits of the funding available, we can we can do a lot, such as, for example, paying qualified interpreters, having the right people to do the job, something like having support for for uh, for clients, such as example from our data, it shows that transportation is a big problem. So funding makes a lot of difference in starting up a program, maintaining and sustaining a program. And although I would like to say make give us give us enough, but I will settle with any kind of funding and I will work with you on that. All because if we wait for an adequate funding, it may not come. So we will not have that program. I will settle for whatever is available. Just start it. And in my work with the Virginia Refugee Healing Partnership, we do operate a lot of programs on a volunteer basis. We have we have conferences that are run by volunteers, and it is being attended by people from Virginia, from 32 states in the United States, and maybe a dozen more representatives from other countries. So what I'm saying here, my message is that let not limited funding stop you from doing something that would support to improve access to mental health services. Start with something. It could be small, but we can always grow big. And that is what I'm hoping for.
Thank you, Dr. Stitt. So what advice would you have? And you've already kind of touched on this, but specifically for advocates, legislators, or state behavioral health departments who are looking to establish something similar to the Virginia Refugee Healing Partnership in their states. What would you say are the essential components that they should put into place to start such a partnership?
Thank you. That's really a very good question. Um, let's start with, and this is just my probably more of a recommendation rather than an advice. I work at the state level, but I'm not an expert. I'm experienced, but I'm not expert. So I would say my recommendation would first be buy-in from key leadership, because without this buy-in or a go signal or a support from key leadership, any person doing the programming will have a very, very, very hard time. Uh, Key leadership can provide us with some funding. Key leadership can provide hiring of personnel dedicated to the program, or uh, key leadership can provide empowerment. Decisions are to be made when you are representing or organizing a program. Decisions need to be made. And if you are representing but do not have this empowerment, and you don't know what to do, you need to consult 5 other people before you can make a decision, you don't get the trust of the community. So I would say that whoever plans to do this need to get a buy-in from the leadership and ask for for an empowerment at some level. It doesn't have to be huge, something equitable to the position that you are tasked to do. Because it's always nice to be given a responsibility that is equipped with the empowerment to do what you are supposed to do so you can be effective. The second recommendation I would say would be connect and listen to the community. As mentioned by my colleague, data speaks a lot, but data is not equivalent to the priorities identified by the community. So between data and the qualitative uh, response of the community, I will always go with the response of the community. It's the quality of the programming, and the acceptance of the program really depends on who are the target of this program. If we don't have good connection and good collaboration, then we will not have a single point of um, of where we are going, the direction of where the program is going. So I would say if you are at the state level, or you are a policymaker, or you are a legislator, please connect and listen to the community. And the last, I really want to emphasize on funding, no matter how small. Big is better, but no matter how small, any program you launch need funding. Example of these would be basic to organizing a program is the travel expense of the coordinator, the development of materials targeting specific groups, development of customized resources. Probably if we need a massive information, we may have a meeting or a conference, or something that needs to be uh, where the community is informed. So please, just 3 basics I would recommend is: 1, buy-in from the leadership; 2, connect and listen to the community; and last of all, funding. I hope that helps.
No, that's super helpful. And I think we're seeing some emergent themes here, listening to impacted communities and funding. And I'm seeing questions about funding in the chat. And I wish, I'm sure our speakers will have advice, but it's definitely a challenge that we've heard throughout this project and throughout our research. So definitely some key themes here. I'd like to turn it now to Darlene to talk to us a little bit about the work that CVT does. And maybe you can, briefly touch on some of the federal work, because we've had, a little more focus here at the state level, but I think folks might be wondering what's going on at the federal level. And CVT is, one of the pioneers in this area. So if you can, briefly share some of the work that CVT is doing at the federal level, and then we can move on to the state level, and maybe some key things on what advocates can do to support CVT's work.
Sure. Well, thank you. And thank you everyone for this opportunity. I'm Darlene Lynch. I'm the head of external relations for CVT here in Georgia. It's an honor to be here and to be part of the report. So CVT, as Balkis alluded to, is a pioneer in this area. We have been around since 1985, founded in Minnesota, and we're now the oldest and largest treatment program for refugee survivors of torture and other displaced individuals living in the States. So CVT is also the second largest worldwide. So we have mental health centers in refugee camps and in cities in Africa, Middle East, and in the US, including here in Georgia, where I am. So CVT quickly realized that the demand was greater than we could meet ourselves, and advocating for more resources and more funding has been part of our work from the very beginning. So, one of the things that we do is we have a DC office, and we have a public policy team that works alongside our mental health staff and our training staff and our research staff. And way back, I would say it was 1980, let me just double check, I got the date correct. 1988, CVT was instrumental in passing or getting past the Victim Relief, Torture Victims Relief Act. And so that act helped create a whole new program to provide mental health services, rehabilitative care for torture survivors coming to the US for safety and building happier and healthier lives here. So as a result of that act and reauthorizations, there are now, 36 different treatment programs in 20-something states across the country. What's great about that is that was a source of mental health funding when there was not much out there. And it was open to anybody, whether they were a refugee or an asylum seeker or an asylee who had experienced torture, war, other serious forms of trauma. The problem is they had to meet the definition of torture. So even some war survivors would not have met that definition. So while that program was tremendously helpful in building a network of mental health providers, it only applied to certain individuals who could meet that definition. So what we're seeing now is some attention at all levels, state, local, and international, to mental health care, which is great. We're starting to see the Office of Refugee Resettlement really think about mental health care as part of the baseline resettlement program, not just as this special survivors of torture program. And that's great. We're starting to see SAMHSA really focusing on behavioral health equity and reaching out into communities that might not speak English or might be coming from different cultures. So there's a lot that can be done with these federal sources, federal programs. I would say that to help, we always need people to talk to their federal elected officials and ask them to support these programs, support the Survivors of Torture program, support the refugee resettlement programs, incorporation of mental health care and funding of mental health care, and talk to SAMHSA about making refugees and immigrants a very clear priority of the block grants that they are giving to every state in the country. Right now, they are advising states to support, culturally and linguistically responsive services, but it's not required that states use those block grant funds to support the refugee and immigrant community. So those are a few ways, and I'm happy to share more if anybody wants to get involved on the federal level.
Great. That's super helpful overview and background for everyone. I'd like to now turn it to some of the advocacy efforts that you've done specifically in Georgia. Can you tell us about these bills and why they matter?
Yeah, well, it was great to hear from my colleagues on the panel because so much of what we're doing in Georgia is similar to what they're doing, though maybe we're at an earlier stage. Georgia provides no state funds whatsoever to the refugee resettlement program or to any mental health care for refugees and immigrants in particular. So we had to sort of start from the ground up. And what we did is we joined Mental Health Policy Partnership that had all the big names, NAMI and Mental Health America and the Carter Center, which is based here, and started lifting up our issues with those mainstream kind of mental health advocates. And then we were able to get some language access provisions into a big omnibus bill last year. And Georgia has been undergoing a real transformation of its mental health care system, like many states since COVID. And there's a big desire here in Georgia to go from worst to first. And so that was our opportunity to jump in. And so in this omnibus bill, we got some relatively small language access provisions. And it was just a matter of saying, okay, here's a mental health bill. How do we jump into this? How do we add to this? The biggest impact of those changes was that it showed that a Republican-led bill would include provisions that supported exclusively refugees and immigrants. It was okay to do that. And so that was a major stepping stone that led to this year's progress, where we're very happy to now have a very strong bipartisan support for licensing reform. And I know several folks have talked about that. In Georgia, we have a workforce shortage, just like everybody else. It's bad for everyone, but it's particularly bad for refugees and other immigrants who might not speak English or might come from a culturally different background. And so one of the parts of HB 520, which is our second omnibus mental health bill, would allow a pathway for foreign trained mental health professionals to relicense in Georgia. So right now, for instance, CBT has an amazing translator, but she's a PhD psychologist from Syria with more than 2 decades of experience at working with trauma survivors. And she's working as a translator. We have another person who speaks 4 languages and she's starting her, over from scratch as a psychologist. So these are folks who need to get into the workforce now, and we're starting to see some really good movement at the legislative level on that.
Thank you, Darlene. And licensing is so important because, it's kind of hitting, it's one stone, 2 solutions. You get refugees and immigrants into the workforce and recognize their credentials. And you also create a wider availability of culturally and linguistically responsive providers, of which there's a shortage, as Dr. Stitt mentioned earlier, it's not just interpretation that's needed. It has to also translate culturally the concepts. And Dr. Rida mentioned this too, how one culture expresses, mental health is quite different from another, linguistically, culturally. And so making, diversifying the mental health workforce is really, should be a real key priority, both federally and particularly at the state level. So I just wanted to emphasize that, and it's really fantastic to see that happening in Georgia. The last question I wanted to ask you is, for those who are, this is new to them, and this was, new to me in a lot of ways as we embarked on this, colossal project. What would you advise people who are new to this, who want to do, engage in mental health policy advocacy on behalf of, refugees in their states? What advice would you have? Where should they start? What skills, what knowledge should they seek out?
Yeah, well, thank you. That's a really great question. And I do want to say that listening to the community is first and foremost. And we have heard, particularly since the crisis in Afghanistan, that the top needs are mental health care, housing, and legal services. So top three need over and over and over again that we hear. At CBT, like so many other places, the wait list is so long that we've had to end the wait list and to avoid giving false hope to some folks. I think it's now taking clients again, but I'm not sure. So, this came out of the community, but it also came out of the opportunity we now have, where we are now in a time where mental health is getting a lot of attention from both sides, from Republicans and Democrats, and from business people and clinicians and all different folks. And so this is a really good time to start lifting up the particular mental health issues that impact the clients that we have in the refugee and immigrant community and others. So yes, talk to the community, find out what the needs are, what are the barriers. Interpretation is always a barrier. Transportation is a barrier. Fear of going to a government agency or just trust of going to a government agency for folks that have had bad interactions with their own governments can prevent someone from going to, for instance, a state-run facility, and they may prefer going to a community provider. How do you make that state facility more inviting? So I would say that, but I would say that equally important is educating the mental health community that probably already exists. In Georgia, we have mental health advocates with decades of experience who know very, very little about this community. Unlike Virginia, the Department of Behavioral Health and the refugee coordinator in Georgia have little to do with each other. And so the Department of Behavioral Health doesn't know how many displaced people are coming to Georgia, how many might need mental health care. So, and with so many of these individuals bypassing the Department of Behavioral Health to go to a trusted community provider, it only makes them more invisible. So a big part of what I do is talk to everybody about this community. And so I would advise, get together with the other mental health advocates and educate them. Make sure that behavioral health equity is part of their platform, and be ready to talk about the needs in the refugee and immigrant community. Take advantage of any commissions or study committees that are out there. And then, the other thing that I find increasingly valuable is being on the Behavioral Health Planning and Advisory Council, which every state should have, and it advises the state on how to use SAMHSA block grants. And you need a voice. You need more voices at that table. So by being there, I'm able to advocate for more diverse membership, which we're doing right now, and also advocate that SAMHSA funds be used for this community. So I think those, you know, the connections in the community and also the connections in the policy world, you have to do both. And then you have to just talk.
Thanks, Darlene. I also wanted to kind of add a point that a lot of American Rescue Plan funding went to SAMHSA, and that funding is still available, and there's still time to access that funding. And so that could be a potential source of funding for those, you know, curious where they can access funding, but a lot of it does not go to the refugee and displaced people in their states, and it's fairly significant. I'd like to now, you know, thank you all for sharing about your work. And I'd like to open it now to our audience for questions. If you have a questions, please put it in the Q&A function. I'm going to start with a question about what can refugee resettlement agencies do to better address mental health? And this is a really excellent question, because that's usually a refugee's first contact upon arriving in the United States. So, you know, I don't know which one of you wants to take it, but maybe we can start with Dr. Rida and then move through to everyone else.
Yeah, thank you. I mean, I had the pleasure of working with the refugee resettlement agencies, and they do excellent work. Many times they have heavy caseloads. Many times they have a very limited funding. So I would say focusing on staff, you know, wellness and self-care is very, very important, and building capacity within the organization. At the same time, making sure that, you know, the psychosocial needs are never invisible in any discussion, because many refugees, when they come, they focus only on the materialistic needs. They want to, you know, learn the English language, take children to school, get a green card and all of that. Many times, really, what I see is the impact of trauma on the family unit. So I have a heavy focus on my work on empowering the family structure. And we have talked about programs for, you know, children, which I think are wonderful, because if we reach the children at an early age, hopefully prevention is always better than intervention. At the same time, I'm very excited, like, you know, next month we have a conference in Salem, Oregon about the needs of elder refugees. Many times, you know, senior citizens are not counted, and many times we think that they are doing okay. At the same time, they are, you know, many times feel, you know, neglected, or their expertise is not really counted because they don't master the English language. And sometimes the children, because they learn quickly and get into public schools, that might change dynamics within the family system. Many refugees I work with, they are very scared for the future of their families, because there is a common say in the refugee field that first generation might lose their language, the second generation might lose their culture, and third generation might lose their religion. There is a little bit of truth to that. That's why I think it's very important for families that, you know, live within a nuclear system. They have a grandparent maybe, or a, you know, an uncle in the family. We need to empower everybody within the family system. And what I have found very important also is to really, for having an informal relationship sometimes might be a better approach. So if your client is giving you, you know, cookies, or they want to cook for you as a refugee resettlement agency worker, that's okay. I mean, it's still not a boundary violation. It's not an ethical issue. So try to understand the culture that they're coming from, understand maybe the subtle dynamics about, you know, eye contact, and somebody doesn't want to shake hands. And so know the culture as much as you can. I don't expect you to be an expert on every culture or language or religion, but being curious and respectful and humble, having a student attitude never fails.
Thanks, Dr. Rida. We have a lot of questions in the Q&A, so I want to check in with Dr. Stitt or Darlene if you have anything to add, and then we'll move on to the next question.
Well, I would just say that CVT partners very closely with the resettlement agencies, And so that, for instance, there's a new mental health program for Afghans who've experienced trauma and combat. And so we're working together on that. And they also partner closely with academic institutions who can provide, you know, psychologists in training who can support some of the needs, basic needs with incoming folks. So again, I think it's partnership and network building. And I think that's one of the keys.
Yeah, this is Dr. Stead. For Virginia, we also work with the different refugee resettlements, as well as in my department, we work with community services boards and private clinics who have the capacity to provide mental health care, treatment, and support. We know that mental health needs is huge, especially for the Afghan group who just came in, you know, with unprecedented number. So we work with several groups, but the biggest project we are to start is, like what Darlene mentioned, is this grant for services to Afghans who have experienced trauma or combat. And so we will work, we are starting to implement the program, but the bottom line of that program is working with the different community groups to provide culturally and linguistically sensitive services in collaboration and in partnership with our 3 big clinics who are helping us develop and implement a pathway, a referral pathway, so that we don't have to take clients case by case, but rather work in a way that we become more efficient by having a standard procedure as well as a referral system for our refugee and immigrant populations. But working with mental health group, it's basically working with and connecting with the different refugee resettlement and the different clinics, mental health clinics, who are willing to provide support and probably, I would say, an extra care for linguistically and culturally appropriate services to people who need mental health care, because it's a double whammy when someone needs mental health care and they don't speak the language and they come to a place where they are not culturally and linguistically sensitive. So it hurts. These people already suffering from mental health, and where they go, they're not given this much respect and attention. So it's very, very important to establish that right at the beginning, because when people are hurt and you hurt them more by not being attentive to their culture, it's not really a very effective and efficient way of doing service.
We're running low on time, unfortunately, and we still have a lot of questions in the chat. If we can put the lab's email in the chat for folks to reach out post webinar, hopefully we can get those questions answered for you. In the last minute that we have, I just wanted to ask one last question, because I think it's an important one. a lot of refugees are not eligible for a lot of these services after 1 year after resettlement. What's available to refugees who have been here longer but still need mental health supports? And we have 1 last minute, so I'm going to throw this at you, Darlene, to close us off, and then we'll close up.
Well, it's pretty limited, unfortunately. CBT, that's what we do. There's no time limit on our services, and there's no cost to those services. And the funding we get, as I mentioned earlier, is largely from the Office of Refugee Resettlement's Survivor of Torture program. There are other community providers that you can turn to, and sometimes the state's safety net providers can see certain individuals as well. But I think you put your finger on a key gap in the system, which is there's very limited care after that period expires.
Thank you, Darlene. Sorry, I am just trying to answer some of these questions in the chat. We had a question about Dr. Rida's book, and I am just posting it in the chat right now. Thank you all, Dr. Rida, Dr. Stitt, and Darlene for joining us today. This has been a really captivating conversation. I wish we had more time because clearly, you know, this is a very in-depth topic and a complex topic, and our audience, I apologize that we weren't able to get to everybody's questions, but I encourage you to reach out to the lab, and we will endeavor to answer these questions for you. Thank you everyone for joining us today. We hope you'll have a chance to take a look at the report. There's a ton of information in there as well. And if you're working on any initiatives within your state or are looking to partner with organizations, reach out and we'll do our best to connect you with the right people in your states. Thank you very much.